X, a 40-year-old female, no comorbidities, working as a housemaid, complains of weakness for 1.5 years. Started in the right upper limb as muscle cramps and pain. Later, she noticed that she is not able to take things above her head and apparent wasting of her arms. She was able to hold a glass of water but not able to take it to her mouth. Not able to get up from bed but can roll over. Difficulty in flexing and extending neck. She is able to walk properly without support, but someone should help her to stand up. She is able to put chappals and no history of slippage of chappals. Now she also complains of difficulty in chewing and swallowing, but never regurgitated or aspirated. No history of nasal twang, change in voice, dysarthria, diurnal variation, exertional dyspnea, sensory disturbances. For 2 months of onset of illness, she is being bathed, groomed, and fed by her daughter, takes to and from toilet, uh, and she has lost her job. When probed further, she said there is occasional twitching of her muscles.
So, what do you make out of this patient?
Sir, patient has muscle cramps and pain, sir, and then apparent wasting of her arms.
What does wasting indicate to you?
Sir, wasting of muscles of the upper limb indicates also she has wasting weakness for 1.5 years.
What does wasting indicate to you?
Sir, wasting indicates that muscles have undergone atrophy, sir.
What does it mean to you?
Element lesion.
Element lesion. Okay. It started in the right upper limb, then both upper limbs.
Yes, sir.
Yes. Then what else you wake out of this?
Sir, she was able to hold a glass but not able to take it to her mouth. That could be due to the wasting, sir.
Due to?
Wasting of the arms.
Can you still tell more about it? Can you make out anything more about it? Okay. Next sentence.
Not able to get up from bed but can roll over.
Yes. So, what are the muscles required to roll over? What are the muscles required to get up?
Sir, muscles required to get up are the flexor muscles of the neck, sir, and latissimus dorsi.
Abdominal muscles.
Abdominal, transverse abdominis, rectus abdominis.
Yes.
To roll over, they are needed, sir.
And what are the muscles required to roll in the bed?
So, roll in the bed, serratus anterior, latissimus dorsi, supraspinatus, and rhomboides are required, sir.
You also require the paraspinal muscles.
Yes, sir.
And then she had difficulty in flexing and extending the neck. So,
yes, sir.
Can you just tell briefly what are the flexors of the neck?
Sir, flexors of the neck, platysma is the main flexor of the neck, sir.
Longus capitis, longus coliae, and rectus capitis are also flexors. What about extensors?
Extensors of the neck are
spinalis capitis and spinalis cervicalis. And trapezius may help you, and sternomastoid may also help you. So additionally, there are other muscles also coming up.
Yes, sir.
Then she is able to walk properly without support. But to stand up, somebody should help. What do you mean?
Sir, she is not able to initiate movement, sir, for standing up.
What does it mean?
So, initiation of standing up, probably her cerebellum involvement can be there, sir.
She has no difficulty to use her footwear, and she has no difficulty to initiate walking. Once stood, she can walk.
Sir, she is able to put chappals and no history of slippage. She is able to grip her chappals, sir.
That's right. So what does it mean?
So there is no distal muscles are fine muscle movement is not affected, sir.
Distal muscles are okay. Distal muscles are okay. Proximal muscles are involved.
Yes, sir.
Then?
Then she is able complains of difficulty in chewing and swallowing. Pharyngeal muscles are involved, sir. But no, never regurgitated or aspirated. There is no cranial nerve palsy, sir.
Can I ask you which muscles are involved in chewing?
Sir, chewing masticatory muscles, sir. Lateral pterygoid is involved, medial pterygoid is involved, and the muscles of the tongue, genioglossus, hyoglossus.
So pharynx is not required.
Sir, pharynx superior constrictor to push the food inside, sir. Pharynx.
Swallowing, not for chewing.
Yes, sir.
That's right. Okay. So what do you make out in total about this patient? Which part of the nervous system is in trouble?
Sir, yes, apparent wasting has element signs.
That's good.
Like wasting is there. Weakness has been there for 1.5 years.
No, once you say it's a wasting, you said a lower motor neuron lesion. Where exactly you focus the lesion anatomically?
Sir, lower motor neuron lesion below the spinal cord, sir. The level of.
So where do you exactly say from the history what can be the site?
Sir, from the site, cervical region can be involved, sir. Cervical, because the right upper limb has muscle cramps and pain. So cervical region, cord is involved, sir. Cervical cord.
So you said it's a lower motor neuron lesion, no?
Yes, sir. Yes, sir.
When cord is involved, you will have upper motor neuron signs, no?
Yes, sir. Yes, sir.
So,
yes, so below the efferent neurons are involved, sir. The reflex arc below the anterior horn cells can be involved, sir.
So where is the lesion? Myoneural junction, nerves, muscles. Where is the lesion? Plexus, nerves. Where is the lesion?
At the anterior horn cells, sir.
Why do you say so?
Sir, patient has weakness for 1.5 years. Has apparent wasting of arms, for arms.
No. For saying anterior horn cell, what is your finding?
Sir, patient should have fasciculation or fibrillation, sir.
So she has fasciculation, no?
No, sir. No, sir. Twitching of her muscles are there, sir.
That is a clue. That's possibly fasciculation.
Yes, sir.
So your thinking is correct. It is possibly anterior horn cell.
Yes, sir.
But then, looking at the weakness, what's the pattern of weakness here?
Sir, weakness has been chronic. Started from the right upper limb and now has.
No. When you say weakness, you say it is a predominantly proximal weakness.
Yes, sir.
Am I right?
Yes, sir. Predominantly
proximal weakness. So, what are the situations where you get proximal muscle disease? Proximal muscle weakness, a dominant complaint.
Proximal muscle weakness we can get in myopathies, sir. Endocrine myopathies, hypothyroid myopathy, hyperthyroid myopathy, acromegaly. We can get proximal muscle weakness, sir.
Can you get any neuropathy with the proximal muscle weakness?
Yes, sir. We can get neuropathies with proximal muscle weakness also, sir.
Which neuropathy?
Thiamine deficiency can present with proximal weakness, sir.
No. It is an AIDP or CIDP. AIDP is a short duration illness, which is 1.5 years. CIDP can have proximal muscle weakness.
Yes, sir.
Okay. You can have osteomalacia with the proximal weakness.
Yes, sir.
You can have different types of muscular dystrophies with proximal weakness. Like what?
Muscular dystrophies with proximal weakness are myotonica dystrophica, sir. Myotonia dystrophica type 2. Then named myopathies like Miyoshi, Nonaka.
No, Miyoshi is distal, no?
Yes, sir. Distal, sir. Distal.
Becker's myopathy. Now tell me, what are the symptoms etiology to say some weakness is UMN weakness, and what are symptoms suggestive of LMN weakness?
Sir, UMN weakness will be LMN weakness, the muscles going for a disuse atrophy, sir. But in UMN weakness, the muscles are in a constant state of spasticity, sir.
History-wise, how will you make out?
History-wise, in element weakness, initially there is weakness and then there is wasting, sir.
No, in case of UMN lesion, what are the symptoms usually?
UMN lesions, there will be it is accompanied by twitching of the muscles, sir.
No. UMN lesion, usually the patient say, my limb is very heavy.
Yes, sir.
I cannot lift up my hip, cannot flex the hip, flex the knee. So they usually drag it very slowly.
Yes,
so they find it inability to lift from the ground.
Yes,
all because of increased tone. So that's their complaint. Their limb is sticking on to the ground because they cannot lift it up.
Yes, sir.
Okay, so you have concluded here the proximal muscle weakness, LMN lesion, and you think it's an anterior horn cell disease. Am I right?
Yes, sir. Yes, sir.
Now, can you in some conditions where cramp is a presentation neurology?
Sir, cramps we can get in amyotrophic lateral sclerosis, sir. It is called as volitional cramps, sir.
That's
then
right.
In channelopathies can get cramps, sir. Like hypokalemic periodic paralysis, hyperkalemic periodic paralysis. Hypothyroidism we can get cramps, sir. In electrolyte abnormalities like hypokalemia, we can get cramps, sir. And then deficiency of vitamins like vitamin C deficiency, thiamine deficiency, beriberi, we can get cramps, sir.
So once you said that's an anterior horn cell disease, what possibilities you come to?
Sir, anterior horn cell disorder, it could be a motor neuron disease, sir.
So you can conclude that it's an LMN lesion with fasciculation, anterior horn cell disease. Do you think the myopathy is a possibility here?
Sir, myopathy usually is not accompanied by fasciculations or fibrillations, sir. So myopathy is a very low possibility here, sir.
When you come to the neck muscle weakness, what are the differential diagnoses you have got?
Sir, neck muscle weakness, myasthenia gravis, sir. But then with a duration of 1.5 years, it is very less possible, sir. Then polymyositis, neck muscle weakness can be there, sir.
Other conditions?
Other conditions, neck muscle weakness, organophosphorus, OPC poisoning, neck muscle weakness can be there, sir.
When?
Sir? When? In case the patient has intermediate syndrome.
That's right, okay. Neurological diseases with neck weakness?
Tetanus can have neck weakness, sir. That is neck spasm.
That's only spasm. What about, you said the motor neuron disease. Can you have neck muscle weakness, motor neuron disease?
Yes, sir. Yes, sir. ALS can have neck muscle weakness, sir.
And what about the dystrophy myotonica?
You can have neck muscle weakness, sir.
So you have got a couple of possibilities here opening up. So general examination of this patient was like this. Otherwise, it was all normal.
Yes, sir.
Vitals were normal.
Yes, sir.
So let's go to the examination of nervous system.
Higher mental functions normal, cranial nerves normal.
Okay. So we'll see a video now.
Yes, sir.
What do you make out?
Sir, there are small fasciculations in the tongue, sir.
What do you think about the size of the tongue?
Tongue is bulky, sir.
Is it wasted?
Yes, sir. It has undergone wasting, sir. Laterally, it has undergone wasting, sir.
So it's not bulky, it is small. Okay. Yeah. Motor system examination. What do you mean by this fasciculation in the tongue?
Sir, fasciculations in the tongue can be due to motor neuron disease, sir.
Where do you localize then?
Below the 12th nerve nuclei, sir, hypoglossal nerve nuclei.
Where is it situated?
The medulla oblongata, sir.
So why do you say below the hypoglossal? Why not you say hypoglossal nucleus? Is it at the level or above or below?
Sir, it can be at the level or below, both, sir. Because
Okay. Motor system?
Bulk apparent wasting of both the arms.
Which are the muscles in the arm?
Sir, flexor carpi, flexor digitorum profundus, superficialis.
No. Arm.
Sir, arm, biceps, triceps, coracobrachialis. Then the shoulder muscles, sir.
Which one?
Deltoid.
Yes. So what is the root value for deltoid?
Sir, C5, C6, sir.
So what is the root value for? No. Deltoid is C5.
C5.
Biceps is?
C6.
C5, 6. Okay. So can it be a root lesion here?
Sir, in case of root lesion, we cannot be able to explain the tongue, small tongue and fibrillations, the tongue, sir.
And it is bilateral symmetrical.
Bilateral symmetrical, sir.
No root pains. No sensory complaints.
Yes, sir.
So we measured.
Arm, right side 27 centimeter, left side 28 centimeter, forearm 18 centimeter, left 19 centimeter, thigh 44 centimeter, right, thigh 44 centimeter left, calf 32 centimeter, 32 centimeter right and 32 centimeter left, sir. So bilaterally symmetrical wasting is there, sir. Arm and forearm, sir.
Asymmetrical wasting, no?
Symmetrical wasting, 1 centimeter difference is there, sir.
So the symmetrical, there is wasting both sides, but there is a symmetrical wasting. Tone,
upper limb, right side hypotonia, left side hypotonia, lower limb normal, sir. So bilateral upper limb hypotonia, no rigidity or spasticity, sir.
Once you say hypotonia, no rigidity or spasticity, okay.
Yes, sir.
Muscle power?
Sir, muscle power, shoulder abduction 0, right and left adduction 0, external rotation 0, internal rotation 0. Elbow extension right side 2/5, left side 2/5, flexion 2/5, left side 2/5, external rotator 0/5, external rotation of elbow 0/5, internal rotation both the sides 2/5, sir. Wrist extension and flexion 4/5, 4/5 on both the sides. Small muscles of hand are good. Hip abduction 4/5, 4/5 on both the sides. Adduction 4/5 on both the sides. External rotation 4/5 on both the sides. Internal rotation 4/5 on both the sides, sir. Knee extension flexion 4/5 on both the sides. Ankle dorsiflexion 4/5 on both the sides. Plantar flexion 4/5 on both the sides. Flexor hallucis longus is good. Flex, jaw jerk absent, biceps absent, triceps present on both sides. Supinator is inverse supinator, and knee jerk is present on both the sides. Ankle jerk is absent on both the sides. Plantar is extensor, sir.
Yes.
So with these findings, is point towards a motor neuron disease.
No, the upgoing plantar indicates pyramidal lesion.
Yes, sir.
And the triceps jerk is well preserved.
And the supinator is inverse, sir, C18.
So there is a symmetry. So C5 is not working, C6 is possibly not working, and C7, C8 are absolutely normal.
Yes, sir.
So what are situations where you can have this type of pattern? Inversion usually occurs in C5, C6 lesion. There may be additional disc prolapse over there, but in this case there is no history of root pain or sensory loss to account for it.
Yes, sir.
So what you find here is a combination of upper motor neuron with lower motor neuron finding.
Yes, sir. Gait normal. Coordination could not be tested. Postural tremor was present. Involuntary movements as in video. Other systems within normal limits. Fasciculations are seen in the videos, sir.
Okay, that's good. Okay. Yes.
Sir, so fasciculations with a mix of upper motor neuron signs and lower motor neuron signs and an inverse supinator reflex with C5, C6 absent and C7, C8 preserved. Probably it's a motor neuron disease, sir. Amyotrophic lateral sclerosis.
Will you get fasciculation the tongue in amyotrophic lateral sclerosis?
No, sir.
Okay. So there is wasting, there's fasciculation weakness, LMN. Hyperreflexia, extens planar, upgoing, is pyramidal lesion.
Yes, sir.
So what do you want to do next?
Sir, we need to do a MRI spine, sir.
There was minimal amount of disc prolapse at C5, but not impinging on the cord or the nerves. Blood investigations were normal.
Yes, sir.
Electroneuromyography revealed extensive denervation pattern.
So extensive denervation pattern will occur in M&D, sir.
Okay. So how to differentiate from upper motor neuron lesion from lower motor neuron lesion?
Sir, UMN will have spasticity, sir. Spastic bulky muscles. In LMN, will have flaccid muscles, then atrophy. Plantar is usually absent or mute in case of LMN. In UMN lesion, plantar is extensor or upgoing, sir.
Okay. What does fasciculation mean?
Fasciculation means twitching of the muscles, sir. A single group of muscles are excited and hence they cause twitching, sir.
Definition of fasciculation?
Repetitive stimulation of the muscles cause twitching, and each twitch is around 2 to 3 seconds. Appears and disappears.
No, fasciculation means involuntary twitching contraction of a muscle fascicle.
Yes, sir.
And what is fibrillation?
Fibrillation, the fasciculations of the tongue are called fibrillation.
The fibrillation is the involuntary twitching contraction of a single muscle fiber. In a skeletal muscle, you will not be able to see the naked eye.
Yes, sir.
What do you see in the tongue may be fibrillation, but elsewhere it has to be called as fasciculation.
Yes, sir.
The inverse supinator jerk, what does it mean to you?
Sir, inverse supinator C8T1 and biceps will be inverse supinator.
No, not C8T1, C5-6.
In case of the C5, C6 lesions, the biceps will be absent, triceps will be absent, but supinator will be preserved, sir.
No, supinator will also be lost, but when you do the supinator, you will be having extension of your elbow with very prominent contraction of the flexors of your fingers.
Yes, sir.
So all the fingers goes into flexion and the supinator jerk is absent.
Yes, sir.
That is called as inversion.
Yes, sir.
What are the points in favor and against the diagnosis of motor neuron disease in this case?
Sir, in favor is the way the weakness for 1.5 years and then wasting, sir. So it's a chronic disease, slow progressive process. So that goes in favor of motor neuron disease, sir. Fasciculations in favor of motor neuron disease, sir. Even the pharyngeal muscle involvement, the fibrillations of the tongue, all go in favor of motor neuron disease.
The points in favor of the diagnosis is combination of UMN with LMN.
Yes, sir.
Absent sensory signs, absent involvement of 3, 4, 6 cranial nerves, and absence of involvement of the bladder and bowel.
Yes, sir.
These are all particular features of this disease. But what is the point against the diagnosis? The inversion is not a characteristic feature.
Inversion
is not a characteristic feature.
Okay.
And angle jerk is specifically absent.
Yes, sir.
That also needs explanation.
Yes, sir.
What are the points in favor and against myopathy?
Sir, in case of myopathy, the points in favor are the proximal muscles are involved, sir, predominantly compared to the distal muscles.
That's one point, yes.
Then myopathy chronicity, sir, over 1.5 years. Weakness is there and wasting is also there, sir. Weakness goes against myopathy, sir. Only in later stages of myopathy we can have weakness, sir.
And also the absence of reflexes is not in favor of myopathy.
Myopathy, sir.
It will be lost only at the end.
Yes, sir.
So we have a couple of problems here. Now, why you would call this disease as amyotrophic lateral sclerosis? Why the term like this?
Sir, lateral sclerosis because the lateral column tracts are involved, sir. And amyotrophy is the muscles go in for atrophy, sir, in later stages. That's why they call it amyotrophic lateral sclerosis.
So the lateral columns, the dorsolateral area in the spinal cord on autopsy will be hard,
yes,
sclerotic, gliotic. That area is by the corticospinal tract. That is called sclerosed. Same time you find muscles are atrophied. Very good. Yes. What is meant by LMN onset type of amyotrophic lateral sclerosis?
Sir, LMN onset type of amyotrophic lateral sclerosis, the LMN signs present initially, sir, like wasting presence initially more than the volitional cramps. Wasting and then volitional cramps, and then patient goes into have weakness, sir. So
one of the subgroups of motor neuron disease is called as progressive muscular atrophy, where you find that muscles are atrophied, wasted, with the preserved reflexes.
Okay.
That type of disease is called progressive muscular atrophy, and some of them may remain as such, but others gradually may develop UMN signs also, and then become full-fledged amyotrophic lateral sclerosis. So whichever is coming as wasting to start with, subsequently developing the upper motor neuron signs are called as LMN onset ALS. So can you tell something about UMN onset ALS?
Sir, UMN onset ALS usually presents with spasticity, sir.
They present as primary lateral sclerosis.
Yes,
so perimeter lesion. And after many years, they develop LMN signs.
Yes, sir.
They are called as UMN onset type of ALS.
Yes, sir.
When you have primary lateral sclerosis, it very easily mimics hereditary spastic paraplegia. So how will you differentiate between hereditary spastic paraparesis and this type of UMN onset ALS?
Sir, in case of hereditary spastic paraplegia, the predominantly only UMN signs will be there, sir.
In a primary lateral sclerosis also, it is like that.
Sir, but the hereditary spastic paraparesis runs in families, sir.
That is true.
Onset is early, sir. Onset is early, sir.
And clinically, one difference is it predominantly affects the lower limb. Upper limbs are commonly spared.
Yes, sir.
It may develop later on.
Yes, sir.
Now, tell me what is meant by bulbar onset ALS?
Sir, bulbar onset ALS affects the motor neurons in the medulla oblongata, sir. So initially the difficulty will be the pharyngeal muscles are affected, swallowing, dysphagia. Patients will present with complaints like dysphagia, dysarthria, sir.
Okay. So what is flail arm ALS?
So, flail limb, there will be sudden, in case of flail limb phenomenon, there will be sudden flailing of the limbs, sir. Like
brachial amyotrophic diplegia, element with weakness, predominantly proximally, asymmetrical, and this group of conditions commonly they live long, but terminally they will have respiratory muscle involvement. What is flail-like syndrome?
Flail-like bilateral lower limb involvement will be more, sir.
It is something like a pseudo polyneuritis. In polyneuritis, as you know, it is the distal muscle that is weak. Here it happens like that.
Yes,
and
sir.
Weakness wasting of distally, and
yes,
they live long, and they progress very, very slowly.
Yes.
Now, what is done by ALS plus syndrome?
ALS plus. They have a degeneration of the brain in combination to the motor neurons, sir.
Actually, the motor neuron disease affects the Bradman's area 4, and the axons are cells are degenerated there, and then it comes down to corona radiata, internal capsule, through the pons, cerebellar peduncles,
yes, sir.
pyramids, and come to the spinal cord as corticospinal tract. So corona radiata is there, internal capsule is there, peduncle is there, then the pontine base and medial pyramid, then your spinal cord, lateral spinal thalamic tract, all these can be affected.
Yes,
but sometimes the degeneration occur outside the classical voluntary motor area.
Yes, sir.
Outside the area 4. So in this type of patients can present as dementia, frontotemporal dementia.
Yes, sir.
Autonomic insufficiencies, Parkinsonian features.
Yes, sir.
Nuclear gaze palsy, and rarely, very rarely, even sensory.
Yes, sir.
So this is what's called as ALS plus syndrome. What is monomelic motor neuron disease?
Monomelic motor neuron disease is it will affect by only one limb, sir.
So yes, that's right. But what is the peculiarity of this entity?
Peculiarity is it is static, sir.
It is static, that's correct. Prognosis very good. Prognosis very good. Have you heard an entity called Madras motor neuron disease?
Yes, sir. Madras motor neuron disease will affect the 8th cranial limb also, sir, along with the motor neuron features.
That term is not yet used. No, nowadays not used.
Yes, sir.
Yesterday years it was very common. So coming to differential diagnosis, why can't it be a case of disc prolapse? There is a inversion of the biceps jerk.
Sir, but disc prolapse, no pain, sir. Pain is not there, sir.
As you rightly said, cervical muscles neck muscles are involved, there's fasciculation of the tongue, and proximal muscle weakness of the lower limb, and proximal muscle weakness of the upper limb. This pattern you cannot get in disc prolapse. This is symmetry here. Disc prolapse is usually unilateral.
Yes, sir.
So clinically nothing is going with it, but when you screen patients after a certain age, all of us will have some amount of disc prolapse. That does not necessarily mean that this patient has got all the symptoms and signs due to disc prolapse.
Yes, sir.
Can this be brachial amyotrophy?
Sir, brachial amyotrophy, bilaterally upper limbs are involved. But then patient also has lower limb signs, sir.
The brachial amyotrophy is usually unilateral, preceded by severe pain, and usually confined to C5, C6 supplied muscles.
Yes, sir.
Lower limb, neck, and the tongue are not usual. Can this be spinal muscular atrophy?
Spinal muscular atrophy, spinal cord is not involved, sir. Spinal cord, any cord signs like autonomic, bowel or bladder disturbances are not there, sir.
Spinal muscular atrophy, how many types are there?
Sir, SMA
0 to 4, and 4 is the one comes in adult. It is very few patients, and after the age of 30 years, in people who have achieved the milestones, motor milestone normally, they are ambulating normally, who has got lifespan normally, but how do they present to us? Adulthood, SMA type 4, how do they come to us? They come to the history of proximal muscle weakness as in this patient,
Yes,
and
sir.
there may be fasciculation. The site of lesion is in the anterior horn cell, but there is a genetic background.
Yes, sir.
So what is genetic background of this entity?
Sir, autosomal recessive, sir.
Which chromosome is involved?
Sir, in SMA, no, no, sir.
5q. Okay. So there can be and the deficiency of protein. That's how it comes. So how do you differentiate the SMA and motor neuron disease?
Sir, spinal signs are there in SMA, sir. Like
SMA, no human signs.
Yes,
no
sir.
human signs. Okay. And commonly order will be affected first.
Yes,
Are you symmetrical?
yes, sir.
Motor disease, to start with, there may be asymmetry as in this patient. A
Yes,
combination
sir.
of LMN and UMN. And
Yes,
that is
sir.
the common difference between the two. But if you want to confirm SMA, you have to go for genetic studies. Otherwise, you cannot confirm.
Yes, sir.
So SMA, types of SMA, type 4, features, natural history, basic pathology, anatomical sites, anti-horn cell, and there is a common genetic background. So this particular patient we discussed today has got LMN lesion with no sensory loss and fasciculation, combination of human and LMN. So we can conclude that is a possible case of
MND.
MND, yes. So this is possibly MND. We have said a couple of differences between MND and SMA, already we mentioned. And tell me, sir, what is fasciculation?
Sir, fasciculation is the involuntary contraction of a small group of muscles, sir.
Muscle fascicle.
Fascicle.
It will not move a joint unless it is in the fingers. So
Yes,
okay. So what is the difference between fibrillation and fasciculation?
Fibrillation is the involuntary contraction of a single muscle unit, sir. Muscular unit.
Not unit. Fiber.
Fiber, sir.
And muscle unit is fasciculation.
Yes, sir.
How do you elicit fasciculation?
Sir, we have to tap the muscle, bulk of the muscle to see whether fasciculation are present or not, sir. Repetitive tapping, repetitive stimulation of the muscle, sir.
Any other technique? You have to hyperventilate the patient.
Yes, sir.
Or you have to apply something cold like either alcohol or sanitizer on the skin, and easily it will come out.
Yes, sir.
So what is benign fasciculation?
Sir, benign fasciculations, sometimes fasciculations can be present seen in thin individuals, sir.
Fasciculation is commonly seen in healthy young adults. And they will come for consultation. And how will you say it is normal or it is a difficult thing?
Sir, if benign fasciculations, they don't have any other features, sir, like blood plantar should be double.
No. 2 points you must always look for: weakness and wasting.
Yes, sir.
If weakness and wasting is there, that is organic.
Yes, sir.
And not fasciculation. So tell some conditions where fasciculations are commonly seen.
Sir, in motor neuron disease, sir.
Other than that?
Hyperthyroidism fasciculations are seen, sir.
Very, very good. What else? In ICU?
Sir, in ICU.
In toxicology?
Sir, in neuroleptic malignant syndrome, in organophosphorus.
No, organophosphorus poisoning. That's right. So, what is the natural history of these patients?
Sir, anti-horn disease, slow, degenerative and progressive, sir. Around 5 to, survival is around 5 to 6 years, sir, after diagnosis.
Oh, yeah, different varieties like bulbar palsy, pseudobulbar palsy, progressive muscular atrophy, ALS, all having same prognosis?
No, sir. Like, all have a poor prognosis, sir.
Okay, you all have poor prognosis, but relatively ALS better than the bulbar palsy and pseudobulbar palsy. Progressive muscular atrophy may remain like that, and that has got very good prognosis.
Yes,
Primary lateral sclerosis, it may take time to evolve into full-fledged ALS. So it has also a better prognosis. But once bulb gets affected, things are very complicated. So
yes,
pseudobulbar palsy is also a problem. So how will you diagnose pseudobulbar palsy?
sir, we have to check for emotional ability also, sir. There is
Yes.
any
Yes, anything else?
emotional ability is there in case of pseudobulbar palsy. Any associated facial nerve involvement is there or not?
Pseudobulbar palsy, what are 3 symptoms you think of?
Sir,
Emotional incontinence is one.
then dysphagia, sir.
Dysarthria, dysphagia, dysphonia. 3 Ds. And emotional incontinence. And what sign will elicit?
Sign.
Exaggerated jaw jerk.
Yes, sir.
And what happened to gag reflex?
Will be
Brisk. Brisk. Okay. So, and can you tell some causes for the pseudobulbar palsy?
Sir, neurosyphilis can cause pseudobulbar palsy, sir.
Commonly, pseudobulbar palsy occur in the background of motor neuron disease.
Yes.
It occur in the background of multiple sclerosis.
Yes, sir.
But more commonly, you get in the bilateral cerebrovascular accidents.
Yes, sir.
TVAs. These are 3 common things for pseudobulbar palsy.
Yes, sir.
So, ultimately, so we have gone for the investigations. We have concluded that this patient had anti-horn cell disease. Possibly ALS was a beginning. The patient is slowly developing symptoms pertaining to bulbar. So she is progressing to even bulbar palsy.
Yes, sir.
What is post-polio syndrome?
Sir, post-polio syndrome is the residual paralysis which we get in post-polio, sir.
Post-polio syndrome is commonly what happens is post-polio syndrome is people who have got polio have residual paralysis. They move around okay for some time, and after few years, 10, 20, 30 years, they come with progressive weakness, and then you find this type of fasciculations. That situation is called as post-polio syndrome. So delayed progression of the disease with appearance of fasciculation. Fasciculation means there is something going on. Suppose this patient has got fasciculation, and after 6 months the patient comes back to you and says fasciculation has disappeared. Is it a good sign or a bad sign?
Sir, it's a bad sign, sir. In case of severe, we don't see fasciculations.
No. Fasciculation once present, when it becomes disappear, the inference is the degeneration or irritation has stopped. So that particular area, disease is arrested. That's good. That's good. But on the other hand, if more and more areas are showing fasciculation, that means the disease becoming active and becoming progressive.
Yes, sir.
So, which are the element lesions where these fasciculations cannot be seen?
Fasciculations cannot be seen in element lesions. Neuropathies, fasciculations we don't get, sir. Neuropathies we don't get fasciculations, sir. Then neuromuscular junction disorders, we don't get fasciculations. The peripheral nerve involvement, we don't get fasciculations.
Okay. Fasciculations indicate that's an acute disease. No. Fasciculation indicates chronic, irritative, degenerative lesion. Acute diseases like polio, you will not get
fasciculation.
But chronic diseases where degeneration is taking place, then you are likely to get the disease.
Yes.
So we conclude that it's a case of anterior horn cell disease. Presentation was odd, and she was moving around from doctor to doctor in search of a final diagnosis.
Yes,
and
sir.
Here we come out with the answer: it's anterior horn cell disease. Maybe it's a late diagnosis. By the time the patient is presented with the fasciculation of the tongue, that means bulb is getting affected, and she cannot get up from the seat. She cannot do anything herself. She cannot even eat. Only distal muscles are powerful, but she cannot bring her hand to the mouth. So it's a very disabling disease so far. How do these people die?
So they die of bulbar involvement, sir. Bulbar involvement is final. Respiratory muscle depression, respiratory muscle weakness.
Also they may aspirate.
Yes, sir.
And they get a respiratory failure or pneumonia, bronchopneumonia, and that's how they die.
Yes, sir.
Okay. Vignesh, do you have any doubt? Do you have any doubt?
No, sir.
Thank you so much.
Thank you, sir. Thank you, sir.